Well, thank you very much for being here. Thank you for letting me join you for your meeting, and thank you also to Dr. Hutzel and his wife from Knoxville, Iowa, who seemed to think it was worth coming to hear more about Viktor Frankl and some of these existential concepts. So there may even be people that are watching this live, and if that didn't give me enough stage fright, I also have agreed to film this with some kind assistance, and other people may wish to even watch this at some future time. So the title I was encouraged to run with is When Distress is Not a Disorder, Existential Approaches to Sadness and Anxiety in Primary Care. And I'm especially interested in this because I trained as a family physician, partly because I had a real interest already as a student in Viktor Frankl's ideas, and I was worried that if I did psychiatry training, I would have 5 years of people saying, no, you should use this approach, whereas I did family medicine training, and they were much more supportive of me picking and choosing which psychological approaches might appeal to me, and this is the one that I personally identify quite strongly with. So I suppose it would be useful to find out how many of you are even familiar with Viktor Frankl. Is he a little bit known? Okay, well look, I will encourage a little bit of discussion even during the presentation. Yeah, for those of you that aren't so familiar with Viktor Frankl, he was an Austrian psychiatrist who wrote books, in particular one called Man's Search for Meaning, and really was probably one of the people who promoted the whole notion of existential psychotherapy. Frankl's worldview was very much based on the notion that humans are seeking meaning, and that meaning is potentially available for any person at any time under any circumstances, and sometimes people find it and go for it and derive considerable satisfaction from doing something meaningful. Sometimes people say, that looks meaningful but hard, I think I'll do something else. They may find life less satisfying. So the idea is that meaning is available but not automatic. And sometimes people do things that look easy but not meaningful. And I've just skipped over the slide from the Australian author Germaine Greer, who was invited to give a presentation at a College of GPs, College of Family Physicians meeting in Australia, where she said there is no pill for the human condition. So there are a few other people that also believe someone might express distress, someone might say that they're suffering, and that doesn't automatically mean they must have a depressive disorder or an anxiety disorder. Oops, so Frankl was also echoed by a professor of family medicine from McMaster University in Canada, saying the majority of so-called mental illnesses, however, are existential crises, the majority of psychological presentations to family physicians are existential crises, problems of the human spirit rather than illnesses. And I suppose there is a certain amount of concern worldwide at whether too many people present to a family physician saying, I feel down, and leave with a prescription for medication. Some people, on the other hand, may leave without a prescription for medication who really do need it. So I'm not here to say no one should be on antidepressants or no one should be on antipsychotics, but I am here to say it makes a difference working out who needs what. And sometimes what people need is understanding, clarification, perhaps even an encouragement to change the thing in their situation that needs changing. And we might have time to talk about Frankl's approach to those people who are in a situation where there is suffering, where there is distress, and the situation can't be changed. But I haven't met Professor John Reed, but he's also coming up with the idea that sometimes there are people with distress and despair who do not actually need medical treatments because they're experiencing an understandable reaction to a stressful life event or an adverse life event. So if that's the case, then the person, and perhaps they don't qualify as a patient yet if they haven't got a disorder, the person might respond better to human responses rather than medication or other forms of treatment. Once again, I've worked in a community mental health team where I prescribed a lot of medication, where I would sometimes go with a mental health colleague and sometimes with the help of the police and the ambulance, where we get people brought into hospital for involuntary treatment. So sometimes there is definitely pathology and there is definitely a need for quite assertive treatment, but not always. And I suspect Alan Francis, who was involved in writing a lot of the DSM-4, has written a book where he's expressing his concern about the way DSM-5 perhaps makes it too easy to say that more and more people have a psychological disorder. And these are quotes from two different statements he made on the internet recently. One of them saying, if only docs talk to patients more and prescribe less. In other places, he's once again quite quick to say there are lots of people that need medication and lots of people that need powerful treatment, but not everyone. And another study he was concerned about was giving the impression that almost everybody has a psychiatric illness at some point in their life. And I think he would agree that suffering and distress are widespread, but perhaps not always best viewed as an illness. So these are some of Frankl's, at the top, the better-known writings, and at the bottom, one of the less well-known writings that was only available in German until a little while ago, when two people in the neighbouring state to mine, I'm from South Australia, these people were from Victoria, and one of them had a particular reason for being involved in the translation. That was his niece, Viktor Frankl's niece, Lisa Cosma. There's now a little group of people setting up the Viktor Frankl Institute of Australia, and Rabbi Dr. Shimon Cohen is one of the people involved in that. I'm another one, and I won't list all of the people, but we're hoping that good things will come of this. That's our town, and our river looks really nice because they had to put in a special weir to make it wide enough to look like a real river. I think you are way ahead of us in rivers. So these are some of the other people that could also be thought of as existential psychotherapists. And a few of them are homegrown North American. Ernesto Spinelli is a homegrown Canadian Italian Englishman. There is perhaps a bit of a trend here that there's a possibly more than average level of travel involved in becoming an existential psychotherapist. That is an anecdotal observation rather than anything that I could come up with firm evidence for. Some of you may be familiar that there are some people who are thought of as existentialists who are in fact not particularly uplifting. Anyone want to suggest people who are existential but actually depressing? I have been reliably informed that Jean-Paul Sartre can be uplifting, but I haven't really quite got to that point. But although there are all these divergent points of view within the existential world, the thing that they all have in common, according to a British philosopher named Mary Warnock, is, broadly speaking, the common interest which unites existentialist philosophers is the interest in human freedom. And I guess if I'm talking to family physicians and students and doctors in training, how does that fit in with us? And I think really the big question is, when you have a client or a patient, what freedom do they have? And if there are certain things that they are free to do or not do, what does that mean in terms of being responsible? And if I'm free to do things or not do things, what am I responsible for? And why am I here and not somewhere else? And having a walk on the beach with a dog, or so sometimes people have to make choices, and I don't think I have the slide for it, but Irvin Yalom had this rather simple point: for every yes, there is a no. So you can't say yes to everything. You can only be in one place at a time. And most of the time, if you've got a person coming to you for help, you should only make one diagnosis for each symptom. Unfortunately, some of the best information I could draw upon for helping you understand some of these great existential questions comes from a brewery. But I don't know how many of you recognise Friedrich Nietzsche, Franz Kafka, and I think that's Virginia Woolf. I'm not sure whether she would really be keen to be described as an existential writer, but certainly I think it's fair to say she conveyed a sense that there is a fair amount of distress out there. I've done a lot of talking. We're nowhere near halfway through, but I thought if I give people a chance to ask a question or make a comment, it should be a little bit interactive. No, speechless. Certainly one of the important things in taking a history is to let the patient speak and not interrupt them with a whole lot of questions. So sometimes just say, hello, how can I help you? Or hello, what is it that you have come here about? I once said, hello, tell me what's been happening, and 30 minutes later the person said, actually I just want a certificate. So sometimes you need to choose your questions carefully. I've got a few definitions of psychotherapy. Hopefully you've got a little bit of a sense of what we mean when we use the term existential. These are some other people that want you to understand what is meant by using the term psychotherapy. Thomas Schage, perhaps also something of an existentialist, but probably even better known for being an iconoclast, for somebody that really stirs things up. Psychotherapy refers to what two or more people do with, for and to each other by means of verbal and non-verbal messages. It is, in short, a relationship comparable to friendship, marriage, religious observance, advertising or teaching. So that's one rather provocative definition of psychotherapy. Harry Stack Sullivan, who I think is fairly seen as one of the forerunners of interpersonal psychotherapy, for which of course Iowa is rightly famous. But yeah, Harry Stack Sullivan said psychotherapy is a discussion of personal issues between two people, one of them more anxious than the other. And if the therapist develops more anxiety than the patient, he becomes the patient, and the patient becomes the therapist. Furthermore, the patient's self-esteem is radically boosted by being of help to the therapist. So I must, of course, give credit to Irvin Yalom for bringing that beautiful quote to my attention. Ellen Frank, so Frank, not Frankel, talking about interpersonal psychotherapy, saying that the nature of IPT is interpersonal rather than intrapsychic, with a focus on the present rather than on early developmental experiences. The overall goals of treatment are to encourage mastery of current social roles and adaptation to problematic interpersonal interactions. And I think this existential approach is also trying to help people deal with problematic situations, including interpersonal situations. And whilst Professor Scott Stewart from here is certainly one of the world leaders in the field of interpersonal psychotherapy, he did once find an Australian to co-write a book on interpersonal psychotherapy, who actually told me that he saw a fair bit of overlap between existential approaches and interpersonal psychotherapy. One important difference is that in interpersonal psychotherapy, once you've made a diagnosis, then it's strongly recommended that you do some psychoeducation and explain to the person what it is that you mean by saying that they have a depressive disorder. In actual fact, I think that's probably completely appropriate in existential psychotherapy as well. It's only fair that you let the person know why you believe they do have a disorder and what you hope you might be able to offer. But let's come back to this notion that not everyone who suffers is sick. So logotherapy and existential analysis undertake to deal with psychic sufferers who are not sick in the clinical sense. So this is a quote from Viktor Frankl. For our psychotherapy in spiritual terms was specifically designed to handle those suffering over philosophical problems with which life confronts human beings. And this is part of the same quote. In no case should the spiritual problems of a person be written off as a symptom. In every case, these are an accomplishment. And he's sort of contrasting with the work of Oswald Schwartz, who was apparently a World War I urologist who then developed an interest in what later came to be known as psychosomatic medicine. But basically, Frankl here is saying, if somebody says, I am really sad, or I'm really anxious, Frankl would say, well done. That shows great wisdom. It is good that you know that this situation is causing you distress. He's not saying it's good that you're in this situation, but he's saying it's good that you know that there is something wrong happening around you, and if that can be changed, you will not continue to feel this way. Frankl spent time as a doctor with certain restrictions on where he could practice. He was basically born in 1905 when Sigmund Freud was a fairly young man, and by the time Frankl was at high school, Sigmund Freud was becoming famous. Frankl would write to him and Freud would write back. You know, sometimes you write to people and they don't write back. Freud thought enough of Viktor Frankl to write back, and they got into quite a lot of dialogue. But after a while, once Frankl finally qualified as a medical practitioner and then as a neurologist and psychiatrist, he couldn't keep working in the main university hospital because he was Jewish, and the Austrian government had become part of the German government, and things were difficult for people. Just to make sure no one's under the misapprehension that that's where all his ideas came from, he'd actually published quite a lot of his key concepts even before some of his personal freedoms were restricted. So although I think a lot of readers find it very powerful that his book Man's Search for Meaning was written and published after being released from concentration camps, it was really before the concentration camp experience that he already formed nearly all of his key ideas. Frankl contrasted his approach with that of Sigmund Freud. Frankl really wanted people to mainly look at here and now and where to from here. I was a 19-year-old student when I should have been doing my pathology homework, and I walked past the room where my parents were watching television, and I think I was probably originally captivated by the accent. Frankl made jokes about his own accent. He spoke English, I think, very, very well, well enough to make puns. Yeah, his accent was also fairly distinctive, and I thought, who's that? That sounds interesting. And having not yet done any undergraduate psychiatry beyond a little bit of first year behavioural science, I had all kinds of misconceptions. And here was Frankl saying, some people are unhappy in the present, not because of their past, but because of the way they deal with the present. So this is a cartoon by a Melbourne person by the name of Michael Leunig saying, could you possibly tell me my present? I think sometimes people want to talk about the past, and sometimes that can be incredibly helpful if it's done well, but it may also be possible to do good work without having to dig over lots and lots of early memories. And some people can actually just continue to dig over things for such a long time, they never quite get to the present. So this is actually rewording a case that Frankl himself talked about of an American who was in the diplomatic field and was posted from the US to Vienna. So this is obviously after World War II. And the diplomat had already been undergoing psychoanalysis, and his analyst kept saying, every time you say there's something wrong with what the government wants me to do, I think it's really because you identify with the government, you identify the government with your father, you have unresolved conflict with your father, we need to keep dealing with this. Now I understand that had gone on for 5 years, then they were transferred to Vienna, came to see Frankl, and Frankl made his assessment and said, could it possibly be that you actually really disagree with the government policies? And the man said, that sounds incredibly accurate. Changed jobs, and I don't know if he lived happily ever after, but that was perhaps a sense of somebody experiencing distress because of their life circumstances and deciding it would be more meaningful to do something that I can relate to. And I suppose if I risk another analogy with American politics, some of you may recognise in this quote a theme that was probably expressed even more vividly by JFK. So Frankl, first of all, he's making a reference to the, I think, was it a Polish or a Czech astronomer, Copernicus, who got into trouble with the church for saying that the Earth revolves around the sun. Up until then, it was more popular and comfortable to say that the sun revolved around the Earth. And I think Copernicus was criticised for coming up with this other point of view. But basically, Frankl says that sometimes all of us need to look at things perhaps the other way around, and it's life itself that asks questions of man. It's not up to man to question, rather we should recognise that we are questioned, life questions us, we have to respond by being responsible, and we can only answer to life by answering for our own lives. Ask not what your country can do for you, but what you can do for your country. I honestly don't know who came first. The year of publication is the year of the English translation I happen to have, so I'm not going to get into who came first, but Frankl was also very good at saying sometimes two people can both have a really good idea and they can both have arrived at it independently. And he still actually expressed a considerable amount of respect for Sigmund Freud, saying sometimes you can see further if you're standing on the shoulders of a giant. And I hope I'm seeing a little bit further these days. Unfortunately, I'm not quite as young as I used to be. Frankl died in 1997. I work, as well as being a family physician, I ended up spending so much time in hospitals that some people thought I must be a specialist of some other sort. So they decided that I was a specialist in what is in Australia and New Zealand referred to as addiction medicine. I've actually written a paper on why I think the term addiction is actually really off-putting and possibly misleading, but that's perhaps a topic for another day. But I will talk a little bit about substance use and substance use disorders. Frankl talks about the essence of intoxication being one where the person's really not focusing on what's happening around them. People get intoxicated in order to feel different inside. And there can be a lot to it, but Frankl's especially here contrasting that with one of his favourite concepts. He talked about people having some specifically human characteristics, and one of them is self-transcendence, that people want things for a reason outside of themselves. So sometimes we do things for the sake of a friend or a family member, or because we see it as our job, or even because it's some ideal that we feel passionately about. But I tend to think that alcohol use disorders are although there's a lot of discussion about this being a disease, I think it's actually a process that really always starts with a decision. And I think it's easier for some people to decide not to have alcohol. If you're already withdrawing and you have perspiration, nausea, tremor, you're anxious and you can't sleep because of your alcohol withdrawal symptoms, it's quite hard to avoid having alcohol because you know that will make you feel better. But if you will humour me by saying perhaps decisions can play a part, then there's the decision, then there's the alcohol use, then most people want to drink enough that they feel something, so they get intoxicated. But once they've become intoxicated, that might mean that they don't do things as well as they otherwise might. There's social dysfunction. It might mean that there are things they don't get around to doing, or perhaps they don't get selected for certain things. They may then even feel a certain amount of disappointment or remorse or guilt. And if that leads to painful negative feelings, feelings of emptiness and despair, some people choose to take away their feelings by getting intoxicated. So there can be, that's just one way of trying to explain things. This is another way of trying to explain things. I won't torment you with the little diagram that looks like an electrical circuit box, but there are people that try to make it seem that everything, this happens, then that happens, then this happens, then there's this feedback loop. And but one of the people that was involved in the World Health Organization trying to come up with definitions of drug problems said, those of us who've contributed to the literature about models of drug dependence have indulged in irrelevances. We've pursued an abstract scientific course rather than responding to existential needs. And those existential needs are options, freedom to choose, and the centrality of human values. So that's Dr. Les Drew, who was a psychiatrist who was later on working in Canberra and then moved to a smaller, quieter place where he continued to work as a psychiatrist but spent a fair bit of time breeding goats. And so I think he worked out that he wanted a little bit of balance, a little bit of life-work balance. Or should it be work-life balance? I don't think Sir Michael Marmot necessarily would identify as an existentialist or a psychotherapist, but once again, if we're talking about people feeling distress because of their situation, it rather dovetails nicely with the notion of social determinants of health. And just so I'm not only quoting British and Australian references, Arthur Kleinman from Harvard talks about human misery and poverty and oppression, and acknowledges that public health and healthcare technologies have played a part, but really social change, improved housing, better diet, public health things like gutters, sewers, garbage collection, education. These are the things that probably lift the standard of health for whole populations. So I don't stop being physicians, but there might be things that you can do over and above being one-to-one treaters. And sometimes there might even be ways you can influence decision makers and governments. And anyway, these three terms, I actually just use these to remind myself that sometimes there are things that lead to frustration. Sometimes it is good to have connection, and I'll touch on cognition a little bit too. The frustration, a somewhat modern version of Edvard Munch, the scream, but sometimes there is a lot of frustration, but there's a lot of disconnection. And in the substance use area again, the notion that people use or become dependent on substances, it may be because of the nature of society. And I think Bruce Alexander is here talking about Canadian society, but also saying chronic isolation causes people to look for relief. And addicted people can best be helped by restoring their place in a functioning community. How much have you heard about motivational interviewing? And what type of approach is motivational interviewing? Behavioural, systems theory, psychodynamic, or is it existential? So certainly the very first paper written on motivational interviewing by William R. Miller from New Mexico after a sabbatical in Norway includes, you've probably read this part already, so I'll move on to the punchline. This assignment of freedom of choice leads to a more existential approach to counselling. So he's saying the client always had that freedom, but how about we encourage them to think about the fact that they have freedom and see whether, by giving them some information and helping them work out what are the appealing things, what are the good things about my current pattern, and what are the not so good things. But instead of the traditional doctor saying you should stop doing that, the doctor is saying, tell me more what appeals to you, tell me more what bothers you. And then there can be some discussion about how close do you think you are to making a change. But I think also, if somebody does make a change, it's good for us to have acknowledged that there was something that appealed to them, that on some level their pattern of substance use or their behaviour was actually appealing, may not have even been rewarding, but there was something they were hoping to get from it. And this is, once again, coming back to Frankl's concept of self-transcendence, that people are inclined to do things not just so that I feel better, not just so that I derive greater pleasure, but people do things in order to relate to something outside of ourselves. And I want to talk briefly about Australian Aboriginal people and Torres Strait Islanders. I'm certainly in no position to make any comments on what's happened in North America about native rights, and but certainly in Australia there are quite a few outback Aboriginal communities where they've decided that they do not want alcohol to be permitted. So although there might be some stereotypes that suggest lots and lots of Aboriginal people have problems with alcohol, there are some communities that have said, we don't want to be in that situation. And the interesting part from this study is where Maggie Brady highlights the fact that there are people who've had patterns of alcohol use that really fit the definition of alcohol dependence, but who then stop drinking. And she says, please don't call it spontaneous remission, because it probably took a lot of effort and it didn't happen overnight. So she firstly challenges the notion of the term spontaneous, and she also says if you call it remission, you make it sound like it is all about a disease process. And much as I like the American Society for Addiction Medicine, I think we oversimplify things, we over-medicalise things if we say it's a brain disease, because I don't think there are other brain diseases that lead people to go into a particular business, point to a product, take their wallet out and pay for the product. I think there is something about this phenomenon that once again involves decisions, and I don't think there are very many decisions in pneumonia. I could be wrong. And certainly there are lots and lots of triggers for Aboriginal people to feel more distressed. 77% in one study saying there has been a major stressor within the last 12 months, and commonly that will be a bereavement. And working with Aboriginal colleagues, we have to anticipate that there will be more people taking time off to go to funerals because there are more deaths in any one person's network of family and acquaintances. And there probably are higher rates of depressive disorder, substance use disorder, and comorbidity and PTSD. Also, we've had patterns where, in addition to standard alcohol, tobacco, cannabis, amphetamines, opiates, there have been probably a greater proportion of substance use within the Aboriginal community may involve solvents, so paint sniffing, petrol sniffing, and there have been some public health measures where they've tried to make it that certain towns where that was a big issue, the gasoline supply, the petrol supply has changed over so that the people that still continue with this behaviour are not exposed to so much lead. So I suppose, whilst this is certainly not a particular existential phenomenon, I guess it's good if I raise the topic of harm minimisation as well, because some people aren't quite ready to stop doing what they're doing. If I do now come back to an existential phenomenon, where somebody I worked with did have a confirmed psychotic disorder, and members of her own family and community said these phenomena are not culturally appropriate. This is not the typical grief-associated hallucination. This person's hallucinations are a feature of an illness. But when the person said, there are people that come to my house in the middle of the night knocking on my door looking for a sex worker, people that come to my house in the middle of the night looking for a drug dealer, the social worker on our team said, they're getting mixed up with the house next door. So whilst we might not have been totally effective in treating the psychosis, the person's quality of life improved immensely when she was relocated away from the house with the sex workers and the drug dealers. So there was an illness and there was a stressful situation, and we did something about the stressful situation, and hopefully we helped a bit with the illness too. Perhaps I won't spend a lot of time on gambling, but I suppose it's a behavioural problem that sometimes is overlooked, and it's probably good. I hope you all take a good history and ask people how many days a week they use alcohol, that you check whether people use tobacco, but you might even just touch on, do you ever have a bet on the horses, do you play slot machines, do you buy lottery tickets? Not saying, do you gamble, but just say, can we just ask about these other things too? There's often a huge overlap between alcohol dependence, opiate dependence, and once again, if people have some of these problems, what do they do with their lives when they stop? My last little chunk is to talk about cognition, and I think I took this photo not far from here, but whilst delirium tremens is a serious medical condition, Australia probably at one stage led the world in Wernicke-Korsakoff syndrome. We have since added thiamine to all flour used for bread making. It probably would make more sense to add thiamine to beer and wine, but the flour and bread making industry was much easier to work with. But if we're talking about various approaches and the fact that things in a person's life make a big difference, I should have left myself more time to talk about homelessness, but certainly that is an area where there will be lots and lots of stresses, and perhaps people become homeless because they weren't handling things in the first place. But if they didn't already have a substance use disorder, becoming homeless probably aggravates people's substance use, and then makes them even more vulnerable to brain injury. Firstly, just from being physically assaulted, being punched out, being concussed, possibly motor vehicle injuries. But I have a particular interest in alcohol-related brain damage, and not just the thiamine deficiency issues. And I came across a study that pointed out that people who are medical ward inpatients, the ones who are hardest to discharge, sometimes are people where they have some cognitive impairment based on their long-term use of alcohol. And Dr. Hutzel, I think you noticed that in your work as well, that long-term alcohol use at high levels, not everyone immediately thinks of cognitive impairment because people often retain their social skills, their verbal fluency, but yeah, it can be quite a major issue. Now, I was asking people to interact and I seem to have failed miserably, but I suppose even if I can't get you to do what you want, well, maybe you did want to listen, but I think it's really important to work out what the clients want. Thank you.
So some of what you've described is existential, and yet the problems or the solutions to the problems are what I would think is anything but existential, meaning moving the person to a different home, feeding people, giving them shelter, which are not what I would consider existential. And I guess, are you going to wrap this around so that they'll be pulled together?
To a certain extent, but perhaps somehow throughout my career I've identified as existential, but perhaps also maintained a bit of a public health approach as well. And sometimes knowing that when I would say to each individual who smoked cigarettes, this is doing you harm, you'd be better off if you stopped, I noticed that after the federal budget came out and the price of tobacco went up, people would then come back suddenly interested in changing. So sometimes I suppose I'm going to encourage you to look at times when there might be a synergy between what you can do as an individual treating single patients and what might be happening when things change in the community or things change in society.
So then in that situation, as an existentialist, are you bothered that the government is taking away a choice? Because to some degree, the government is limiting the choice there, which I don't have too much of a problem with, but maybe I'm not a real existentialist.
I think the individual's right to continue to use tobacco, I don't think the government, if they said you will go to jail if you use tobacco, that would be taking away their choice. Saying we will make it more expensive, I think that fits with what some of the public health people are saying. They talk about make healthy choices the easy choices. So if it's very hard to buy fresh, healthy, unprocessed food, but very easy to find, perhaps I shouldn't name brand names here, but certainly in outback Australian populations, it is incredibly expensive and difficult to buy fresh fruit and vegetables, but easy to find things that are probably less recommended as part of a healthy diet. Yeah, maybe I'm promoting a lot of public health ideas, but also wanting you to be aware of existential concepts. Perhaps I will just come back to...
I mean, I guess I would say my argument on that one a little bit is that you're also then putting the full cost of that decision onto the person, because there are some ways that we have kept the cost of smoking or making poor health choices artificially low, and by using some of these government mechanisms to redistribute the costs to the people who are actually making decisions, I think would still stick with the existentialist concept. So in a way, I'm not sure those things can't be combined, because we have ways of buffering the costs of the consequences, and by removing that buffer, or at least decreasing that buffer, we actually are making it more possible to for folks to make informed choices based on the true cost. So I guess I have chosen over the years to interpret it that way, because I am a big believer in patient choice.
Okay, well, thank you. I think there was something that says I should repeat questions, but I might very quickly see if we can come to some concluding comments. And I understand you all have work to get back to and things to do. So, speaking on behalf of consumers, this was a powerful message from a consumer representative at a meeting I went to, where she said really what people with serious mental illness want is a lot like what other people want. We want a job, a house and a date on Saturday night. And she wasn't saying that there isn't any place for professional support and treatment, but if all we can offer is medication, therapy, admission to hospital, but then the person returns to exactly the same situation, that could add to the impression that nothing changes. And this is perhaps one of the more existential concepts that really people are trying to work out, how do I live my life? And I've seen this quote both in the work of Irvin Yalom and Martin Buber, but basically I don't know much about Susha, but some significant historical Jewish figure saying, when I get to heaven, they're not going to ask me why I wasn't Moses, they're going to ask me why I wasn't myself. Why didn't I become what only I could become? So I think perhaps that's what I would leave you with as a parting thought, that if you can help your patients become who they could become, and if you try to be who you could be, so you don't all have to be Surgeon General, you don't all have to be Governor of the state, you don't all have to be Olympic athletes, but if you've got some strengths and some skills and some passion, see what you can do with it. It's just a few other things if you did want to pursue some of these points further. And I suppose I just like to have a little image of my hometown occasionally. Thank you very much for all your time and attention, and I'm more than happy to stay and continue with any discussion. Thank you again.
Thank you.